Good morning, afternoon, or good evening, wherever you are. And thank you for joining today's Endo-ERN webinar entitled Noonan Syndrome with emphasis on current guidelines regarding growth, endocrinology, and growth hormone therapy. I'm very pleased to introduce you today's speakers, Professor Kees Noordam. He is a pediatric endocrinologist in the Pediatric Endocrinology Center in Zurich, and he's professor at the Radboud University Medical Center in Nijmegen, the Netherlands. Our other speaker is Professor Giovanna Dahlgren, professor of pediatric endocrinology in the University of Gothenburg, Sweden, and working in the Queen Sylvia Children's Hospital. Before we start, I would like to give you some webinar instructions. After the presentation, there will be the opportunity to ask questions. If you press the raise your hand icon, we will unmute you and ask you to speak, or you can leave your question in the question box. This webinar will be recorded for review purposes only, and it will be available afterwards at our Endo-ERN website. After the webinar, you will be asked to complete a short survey, and we would be grateful if you could complete the survey so we can improve the quality of our webinars. For now, I wish you a successful webinar, and Professor Noordam, the floor is yours.
Okay, thank you, Charlotte. It's an honor to present together with Giovanna this webinar on Noonan syndrome. And as a disclaimer, when we start this presentation, it says it's a review of the current guidelines, the revised guidelines. They are in revision, the different guidelines, and of course we participated, but you have to wait a little until the autumn and they will be released. Of course, we will speak in what's being said in these guidelines. I will make a short introduction on Noonan syndrome, what is it, and speak about the diagnosis and what to do thereafter. I will highlight some important problems in Noonan syndrome, like there are feeding problems and problems with psychomotor development and behavior. We then introduce the chapter on growth and puberty, and then Giovanna will further elucidate on the mechanism of the growth failure and growth hormone treatment. First, the case, that's the history of John, who I saw here for 1 year ago when he was 9. He had a normal size at birth, but it was noticed that he had ptosis, low satiety, and a hypotonia. His parents literally went mad because of feeding problems, not eating very slowly and so forth. He had delayed development globally, and he saw a lot of healthcare professionals. He was operated 3 times upon his ptosis, and currently he has emotional problems and pains in his limbs. He had a fairly normal stature and no heart problems. And no one thought about the diagnosis of Noonan syndrome, also not a geneticist. But when he got 8 years old, a woman spoke to his mother and suggested the diagnosis of Noonan syndrome, while her son also has Noonan syndrome. This is not a seldom case, and making a diagnosis of Noonan syndrome can be difficult, although it's rather frequent. So it's very important to share the phenotype with all our colleagues and healthcare professionals. One who did recognize Noonan syndrome was Jacqueline Noonan, the late Jacqueline Noonan. She was a pediatric cardiologist, and she noticed that some of her patients with pulmonary valve stenosis did look alike, like they were family. They had similar facial dysmorphism and all were short. With the help of opiates, she described this entity, and thereafter it was called Noonan syndrome. So the Main features are facial dysmorphism, typical, cardiac defect, and a short stature. When you look at the Noonan syndrome, you see a school child with a typical physiognomy with a hypotelorism, ptosis, an epicanthus, a low nasal bridge, low setios, and a short and broad neck, sometimes also a clear web neck. Other signs, like you see here, are a thoracic deformity. It can be scoliosis, cryptorchidism in boys, coagulation disorders, or hemorrhagic diathesis. They have a delayed psychomotor development, almost all of them. A lot have feeding problems. There are lymphatic malformations in all extensions, and they can have problems with vision and hearing. The diagnosis can be difficult, and to aid this diagnosis, there have been developed scoring systems, and the most known is that of Ineke van der Burgt, presented in 1994. But still, making diagnosis can be difficult, and the phenotype can be varying, and the facial features can become milder over the years. Clearly, it's a genetic condition. And when the first gene in 2001, PTPN11, was discovered, I think no one would have guessed that later on 18 genes were discovered, and still counting, I would say, responsible for the phenotype of Noonan syndrome. Most of the genes are inherited autosomal dominant, and one of the genes, the LCTR1 gene, is also inherited autosomal recessively. It's quite frequent for a seldom disease, and it's estimated that's around 1 in 2,000 newborns. All these genes are involved in the Res-MAP kinase pathway, and these disorders lead to a dysregulation of this pathway and an upregulation, making growth factors and cytokine signal transduction increased. And in cancer cells also these mutations can be found. You can see it in families, of course, with the autosomal dominant inheritance. So it's very helpful. And this, of course, a very obvious case of a mother and a daughter with a pulmonary valve stenosis. But also in milder cases, it can be helpful to see the relatives and to ask about family pictures to make and to aid to make a diagnosis. It's also one of the entities in the scoring system of Ineke van der Burgt. Resopathies, so the Res-MAP kinase pathway, where all the genes of the proteins decoded by the genes are involved. And you see them here. It's a complicated slide, of course, but it's a cell, and it's a cell membrane and a receptor. And then it's transducted over the cell, through the cell, and the Res-MAP kinase pathway. And what you can see is that these genes, so the light red genes, are all involved in Noonan syndrome. There's a genotype-phenotype relationship. So for instance, SOS1, the children are rather tall or have a normal height, and as to PTPN11, the children have a short stature. So they lead to specific combinations of congenital malformation. In the differential diagnosis are syndromes like Costello syndrome, CFC syndrome, Noonan syndrome with multiple lentigines, and the Noonan-like syndrome. It can be difficult to say what syndrome is it Noonan syndrome or is it Noonan syndrome with multiple intentions, but genotyping will help here. Germline mutation, so in every cell of the body is the mutation, leads to the malformations, and also the same mutations are found in tumors leading to cancer. Those are mutations leading to a more increased signal transduction, we think not comparable with normal life-born people. Noonan syndrome has an slightly increased risk of Noonan syndrome, and we think because of upregulation of these pathways. After their diagnosis is made clinically and confirmed as you wish by genotyping, we have gene panels, of course, one should check upon the heart, so make a cardiac ultrasound, check upon growth and weight development, elucidate on the feeding problems, check on bleeding diathesis, foremost when there's an operation scheduled, have an ultrasound of the kidney and evaluate hearing and vision. An important topic are the feeding problems, and very, very disturbing for the parents. And therefore, some of my colleagues say it should be one of the cardinal signs of Noonan syndrome. So you should suspect a child of Noonan syndrome when they have severe feeding problems. They occur about in 60–70% of the children. It's most vomiting, reflux can be seen, and the feedings can take very long. We studied because we asked ourselves, is the relation between growth and infancy that's not so good, and relation with the feeding problems in the first year? We studied 45 infants, of course, somewhat more boys, and this is what we found. So there you have on the x-axis the time, that's in months, 0 to 12, and the z-score on the y-score standing, and the z-score is here for weight in boys. These are boys clearly, but the picture for the height is about the same. And what you can see that all three curves depicting in blue all boys, in purple the feeding problems, and in yellow without any feeding problems are almost the same. So there's no difference, and it seems that having a feeding problem doesn't build or doesn't lead to a decreased growth, but all of the children and infants decrease in height over the first year. So one could say the syndrome is more important than feeding in Noonan syndrome. We don't know that much about this in the first year and what's happening when you would increase caloric intake in the first year, while of course only in the first 6 months, growth is partly dependent on caloric intake and thereafter not. The feeding, you can reassure the parents mostly, while the feeding problems, as severe as they are, mostly disappear in the second year. But of course, you should treat reflux and so forth. After the first year, the parents will tell you that the child has small appetite, is thin, perhaps too thin, but they eat what they need. What can you do? What should you do? Monitoring is necessary. And also always depict weight for height and not only weight for height, and look at it being stable. When there are problems with eating, it can help to involve a speech therapist and involve a dietitian. And with regard to reflux and vomiting, you can follow the guidelines as they are for pediatricians and pediatric gastroenterologists. Of course, there are more severe feeding problems necessitating a multidisciplinary approach, and also tube feeding can be necessary in cases. Here you see an older child is actually the boy I showed you, John. On the right-hand side, you see height for age, and you can see there that he's growing about the 20th centile. What is small for his family, but still on the normal range, with a bone retardation of about 2 years. And still you can see on the left-hand side that weight for height is always on the 3rd centile. I would say the growth pattern right is not as typical for Noonan syndrome, but it's a boy with a SOS1 mutation with a fairly normal height. And the left side, so weight for height, is normally on the 3rd centile. And measures to increase the weight and won't increase statural growth. A word on neurology and behavior. So neurology, it's important to recognize that those children can have malformations like hydrocephalus, craniosynostosis, and Arnold-Chiari malformations, and also can have seizures as a result of an otherwise structured brain. They have a delayed motor development and for most a delayed speech development and behavioral problems. I will elucidate on that later. We recognize since, I would say, 10 years that they can have pains, and that is a feature also of Noonan syndrome. There are abdominal pains, and for most pains in the limbs, so musculoskeletal. It's explained, we think, because of an increased sensibility at the central level. We don't have a real solution for this. Psychomotor development is delayed. On the cognitive side, the IQ is in the lower normal range, but they have more learning problems as a child than you would expect because of language problems, decreased motor skills, and decreased concentration, and on the issue of social and executive skills. It's good to know for the people at school that they learn better with words than from pictures. And it's a peculiarity that they are unable to express their feelings appropriately and to interpret the feelings of others appropriately. But can be difficult in social circumstances. The prognosis of the intelligence is rather good because as adults, the intelligence is still in the lower normal range, but the performal EQ has increased. They also have the alexithymia, so that's the inability to express or to interpret the feelings of others. In children, 70% of the children show symptoms of ADHD, and 20% have a diagnosis of ADHD. This makes, when there is a treatment, of course, the Ritalin makes the question about the growth delay any further. They can be anxious and sometimes have an anxiety disorder. They're introvert, and they can have conflicts because of the inability to judge feelings properly. It's advised to have a neuropsychological evaluation at educational transition phases, like we do that and are familiar to do that with Turner syndrome, to check for ADHD, and the alexithymia, the social problems, can be helped at by training or by psychotherapy. Now I will switch to growth, and here you see the short stature is a cardinal feature. Here you see the growth curves designed by Ranke, and left is the males, right is females, and what you see is that the mean final height is about a -2 standard deviation scores. there's not a clear pubertal growth spurt, but caused by the delayed puberty, there is barely no growth spurt. And you can see that here in boys on the left-hand side, the growth height velocity curve, but the height velocity is always below the 50th centile, and the growth spurt, pubertal growth spurt, is delayed. Is delayed and is decreased. On the right-hand side is the difference between age and bone age, and there it's not clear because it should show that the bone age is retarded with a mean bone age retardation of 2 years. It's important to know, of course, adult height in Noonan syndrome to judge about the final height with growth hormone treatment. And you see three studies from Ranke and Witt. They're somewhat the same. So it's 161 for men and 151 for women. We performed in 2003 a study with Jacqueline Noonan in really adult patients, so men above 24 years old, and then the mean final height in men was 166. It stresses that it's important to do the final measurements when the age is above 24, and we did that in a cohort in Holland, and we studied 71 patients or persons with Noonan syndrome, and the mean adult height was about the -2 standard deviation scores. It was interesting to find that we could find a positive secular trend in persons with Noonan syndrome. So with the generations, they got taller. In people born after 1970, the men had an adult height of 196, and in women 156.5, making a difference of 13 centimeter more, equal to the difference in normal people. These figures were somewhat confirmed by Binder in Germany. Also was confirmed that the people with mutations in PTPN11 are somewhat smaller, so with a half standard deviation score. Some word on the puberty and gonadal function I already mentioned. So the bone age retardation is about 2 years, and you can see that in boys and in girls. So they're delayed and will enter puberty later and after menarche later. Fertility in women seems to be normal, and there are more mothers with Noonan syndrome than there are fathers with Noonan syndrome. In boys, cryptorchidism is frequently seen, about 70%, but also in the boys without cryptorchidism or orchidiopexia, you can find Sertoli cell dysfunction, and you will find elevated FSH levels and a decreased testicular volume. This was the part I will, as an introduction, gave, and now I will hand over to Giovanna, and she will talk about the growth hormone treatment.
Thank you very much. So if you take the next slide, see if we manage this to combine both of us. The next slide. Thank you. So the topic that I will deal with is the background in Noonan children. What about growth hormone secretion? How is IGF-1 levels? What about the outcome on growth hormone? Which predictors do we know about response? What about safety? And then clinical conclusion. So if we take the next slide. This is a scheme of the growth hormone IGF-1 axis, and you may have in Noonan either, if you take the next, either you have a problem on the pituitary level with an abnormal growth hormone pattern, so you have different diurnal secretion with maybe low levels nighttime. So you may have a low growth hormone maximum, either with the spontaneous profile or with the stimulation test, or you may otherwise have more of isoforms like non-22K kilodalton forms. And then the next, you may have, next please, you may have a problem in the growth hormone receptor level, and then the signal into the cell will be not so accurate as it should be, that leading to low IGF-1 levels, or it may be that when you start treating on growth hormone, you don't have the nice change in IGF-1, the delta IGF-1, or you may have a problem on the growth plate with a growth response. So it can be different levels that are abnormal, and I will show you what is published until now. So next, please. We have publications with very few patients, like the one from Ahmed in the beginning of the 90s from the UK cohort. We have publications from Dutch cohort by Noonan, later on by Binder, and recently from Sweden, publication that we had publications in the beginning of 2000 on final height, and then went to go back and look at more detail the growth hormone IGF-1 axis. The next, please. And here to the right, you have the publication from Noonan 2001. And in the upper level, you have the pattern of the Noonan. So you may have a lower growth hormone maximum, and this is with the spontaneous secretion, taken measurements every 20 or 30 minutes. And then you have a bit higher basal levels. So you see that the GH secretion never goes down to 0 as normally it is in the lower panel then. Please, you take the next one. So we know that it is more of a disorganized growth hormone secretion with high basal levels and low spontaneous growth hormone maximum. But when you do the provocation test, then you have either normal or a bit higher growth hormone secretion. So it could be a dysregulation between the hypothalamus and the pituitary. And then it is shown by several publications that this group have low IGF-1 levels at baseline. And if you have the PTPN11 mutation, you have even lower. You can take the next one, please. And then if we compare with and without the PTPN11 mutation, you see this is from the recent publication last year from our group, that you have in the PTPN11 mutated IGF-1 at start of -1.6, and in our group we had even lower mean IGF-1 levels, whereas in other publications you will have the reverse. But in both groups you have a response with a substantial increase in IGF-1 that is more substantial in those that don't have the PTPN11 mutation. Then we take the next one, and here we compared the Noonan group with Turner group. And maybe you know historically, before the entity of Noonan, some clinicians had the definition as male Turner group, but this is wrongly, of course. We know that it's completely different genetic background, but still, when we compare these groups, we can see that in the Turner group we have completely normal or even a bit higher IGF-1 levels as a mean, whereas in the Noonan group as a whole you have low IGF-1 levels and as well IGF-1 BP3, and then you will have also the ratio between them low in the Noonan group compared with the Turner group. We can take the next slide. Here we again compared the both groups, and then after 10 days on growth hormone treatment, you have a rapid increase in IGF-1 of almost more than 3 standard deviations. So this is IGF-1, delta IGF-1 in standard deviations. And then you have as well IGF-1 BP3 also increase in a way that is not so much in the Turner group. So you have a very nice response on growth hormone in the Noonan group as a whole. We take the next one. And if we start to talk about outcome, then in the short term, we have an increase in IGF-1. So Cotterill, again from the UK, showed data from 30 Noonan syndrome. I'm not aware how many of them that had a PTPN11 mutation, but the IGF-1 was of 121. They did not show the data in standard deviations, whereas Nordam published data on 25 that had the mutation out of 27, and they had IGF-1 of minus 0.4. Binder showed data on 17 Noonans, 8 were without the mutation and 11 with the mutation, if I'm correct. And there you could see that those with the PTPN11 mutation had low IGF-1 levels of minus 2 standard deviations compared with minus 1.1 if you did not have the PTPN11. And then we have data from Limal also, in total 25 patients. And again, there it was a low IGF-1 if you had the mutation compared with those that did not have the mutation. Whereas the data from Sweden, it was the reverse. Whatever, what is sure is that when you treat, you will have a better change in IGF-1 if you don't have the mutation. We can take the next one. This is the data from Limal, and here he shows with the figure the data, the IGF-1 with the black dot, those that have the mutation, and open dots without mutation. And this was A and B, and when you have the panel C and D, he shows the change in IGF-1 after starting treatment. It's an increase either if you have the mutation or not, but still there's a difference between the groups. You can take the next one. Next one here. Yeah. And then what about the short-term height outcome then on growth hormone treatment? Again, the data from the UK, there was 30 Noonan children that were treated with growth hormone, and then 10 without growth hormone as a control group. And we did not know which of them that had the PTPN11 mutation, but we know that on 50 microgram per kilo per day, they had a height outcome of 0.65 standard deviations during the first treatment year. Nordam again, data from 27 children, 16 prepubertal, duration of 3 years. Then again with a dose of 50 microgram per kilo per day, they had a height change of 0.5 during the first year. If you take the next slide, and here we have the other data, Binder, data from Germany, showing that with 43 microgram per kilo a day, there was a difference between if you had the PTPN11 mutation, then it was less height gain of 0.7 compared with 1.3. We had data from Osio, the Swedish data. What we showed during the 2 first years on growth hormone treatment in 2 different doses, either 33 microgram or 66 microgram, there was no difference between the PTPN11 positive or negative, although it could be a bias because we had 2 different doses, too few with no strong power, statistical power. That is really a problem with the different cohorts, that it is rather few patients and it needs to be more aggregated data. The study that was most large is the one by Osono from Japan, 51 Noonan syndrome children. There was a randomized study with either 33 or 66 microgram, and they showed that it was a significant better outcome if the patients had a higher dose. So a response of 1.5 almost standard deviations during these 2 years, compared with 0.84 for those with a lower dose. We can take the next slide. On the long term then, again, Osio showed in 18 out of the 25 treated Noonan syndrome that they had a mean gain of 2 standard deviations if they were male and 1.4 standard deviations if they were female. The Noonan study found average 1.3 standard deviations, and then Horikawa, again, follow-up of the Japanese study of 51 Noonan syndrome, but they had only not to final height, but only 4-year data. Again, a reassuring gain that was sustained. And then the larger study by Rohrer, 2021, showed also average gain of 1.3. So there is a substantial gain long term. And then we have, of course, the secular trend that we have to, in a way, compare with non-growth hormone treated Noonans, but this is not really ethical to do. And today we have the indication not only in the US and Japan, but also in Europe, and then it would be very unethical to compare with without treating those Noonans. But based on the data from several randomized studies, based on the long-term, like worldwide in Nordinet, we see that the height long-term is preserved and it's substantial. Please, we take the next slide. And here is the figure showing the data from the 18 children that were included in Osio publication, where you see that they start as an average compared to mid-parental heights then, below -2 standard deviations and reach near -1 standard deviation compared to the parents. We take the next, please. Yeah, again, a substantial gain, height gain, especially in males. So a bit about predictors of good or bad response, which is low delta height. We know, for example, that extremely short parents with Noonan syndrome diagnosis is a bad predictor. Also, low delta IGF-1 during the first year on growth hormone treatment. Those males, especially males that don't have severe delayed puberty, they have also a rapid maturation and not so good improvement to adult height. And then, of course, bad compliance. So these 4 in a regression model were those that showed to be a bad predictor. If we take next one, so then if you have a rise in IGF-1 and IGF-BP3 during the first year of treatment, these will have a very strong correlation to increment in height velocity of R 0.7. And so that's why if you don't have this increase during the first 10 days or first year, you should really rethink about treatment, I would say. Next, please. And here we have the changes in IGF-1 during the first 2 weeks and the response in height SDS. So the shown height velocity is one thing, and here is the delta height from start to 1 year. And it's a strong correlation to the change in IGF-1. We take the next one, please. Next slide. And here we have again what is obvious, I would say. This is a measure of growth hormone secretion of the 24-hour profile. And it's very logic that there is a correlation between the growth hormone maximum from the spontaneous curve compared to the delta height from start to pubertal start. So this is no rock science, but still, you know, those that have very high growth hormone secretion, I really would have a discussion within the clinician group how we should treat. But as you see, those that have moderate growth hormone secretion or low growth hormone secretion will have a benefit of growth hormone treatment. So there's a negative correlation between response in change in height compared to how much the growth hormone secretion is, but even stronger if the delta IGF-1 is there appropriate during the first 2 weeks and first year. We take the next slide. So factors influencing the response is a better growth response if treatment is started early. This is based on data from the Osteo publication and other publications, and the duration of prepubertal growth hormone treatment is also an important contributor to the height gain during prepubertal years. So that's why we also recommend to start treatment early, around the age of 4, for example, and don't wait too near puberty. Here we have the safety data. This is insulin secretion, also in the paper of Osteo, showing that during treatment, as in other diagnoses that we have indication of growth hormone treatment, we have an increase in both in IGF-1 and insulin, and that this is safe. And then when you stop growth hormone treatment, you have the decrease in insulin, and these patients never become severe insulin resistant, and this is transient. Next, please. Yeah, both blood glucose and HbA1c were completely within normal range, and we have seen it in the Swedish data, and we see it also in other publications. The paper by Rohrer shows also that there are very few cases with cardiovascular adverse events, and we believe that this is based on the status already at start of treatment. Most studies have excluded patients with severe hypertrophic cardiomyopathy. Some claim that this could be more severe on treatment, but we lack really data on that. Based on that, most studies have not included severe hypertrophic cardiomyopathy, and you should be a bit careful. In the literature, there are individuals that have neoplasms. In the Swedish data, we had a female that got leukemia, but it was already after 4 months on growth hormone treatment. So we don't know what is the natural development and what is the influence of growth hormone. And we don't we recommend that it's important to follow up the patients, but there is no contraindication due to malignancies. Please, you take the next one. As I mentioned, we had only one child that developed lymphoma, and it was, I think it was, it came already after 4 months, and then one started again treatment, but in the long run, no other severe adverse events. Please, next one. So to conclude, all the published data gives that growth hormone treatment in children with Noonan syndrome gives a substantial height gain, not only in the short run, but also to adult age. Treatment with growth hormones is safe, but the treatment benefit of being carried out at a multidisciplinary pediatric endocrine team with thorough follow-up. We used to recommend yearly follow-up of the blood status, and if the child has some cardiomyopathy, you need to do ultrasound. And it seems not to be a significant dose-dependent response, although the data from Japan is interesting and will be very interesting to get data to adult height to see if the difference between standard dose and double dose is maintained until then, or if the children have early puberty. The response can be followed with IGF-1 measures every year, and you can adjust the dose based on that. Be aware that the majority of males have a late puberty and therefore benefit of treatment until the age of 18 or 19 years of age, until the bone matures completely. The recommendation is to avoid genotypes known to have an increased risk of cancer, but it's not prohibited. And we used in our clinic to have a dialogue with our genetic unit. There is a risk of starting growth hormone treatment in Noonan syndrome patients with severe cardiomyopathy. And we need really in the special units that follow these kids to have an evaluation on the data. So we need more data on this topic. And I recommend yearly ultrasound in our patients. The next one. I think we thank you for have been listening, and now it's open for questions to me and Professor Nora. So the first question from Agnieszka is, would you recommend performing growth hormone stimulation tests before the growth hormone commencement? And how often do you find the necessity to add testosterone, estradiol, progesterone therapy? Well, in Sweden, we are very fond, or we have good experience of doing night profile, the spontaneous profile. So that's what we do. We don't do stimulation test, but I think that it's important to have knowledge of what is the problem, so to say. So if you used to have stimulation test, I would go for that. It's important to have a IGF-1, so you know if they have very low IGF-1, and then as a next step, perform either stimulation test or spontaneous night recording. I don't know if you agree with me.
Yeah, I agree with you. Although we don't measure spontaneous growth hormone secretion. It can be yeah, the Swedes are famous for that, for doing that. And I would check upon growth hormone stimulation tests with very low IGF-1 levels, or when you suspect a pituitary problem caused by a low TSH and low free T4. That I would say.
And in my opinion, you may it could be that you need testosterone for those that are very late in puberty, but I think it's very seldom we use that, and for sure we have not had any problems with females that they have problems with low estradiol or fertility. I don't know if you have other experiences.
Yeah, but the boys, I used it once or twice only to induce puberty. In girls, I used it once or twice also when the height velocity went very low, also during growth hormone therapy, and they were 13, 14, 15 years, but it didn't really increase, so it's very difficult. One have these patients with that are not really good responders, I would say.
In Sweden, we used to have estradiol patches. So we start with low patches nighttime, take out in the morning, and then we increase the dose. Do you treat, if you treat with estradiol, do you do it with pills then?
We do it with pills, yeah, and we have done special deliveries for it. But I think it would be better to use the patches when you're like we do now in Turner syndrome. But we had to develop any experience and didn't do that in Noonan syndrome. And of course, the number of children we treated, since only patients with a proven growth hormone deficiency could be treated, and the growth hormone stimulation tests are perfectly normal. There are being more and more patients included on growth hormone therapy. What's good, I think.
Good. So we have more questions here. We have a question. Signe asked to show slide number 41 again.
And there it is.
The conclusions. Signe, did you want to? Yeah.
Okay, perhaps to see the conclusions and to take a question, it will be available afterwards, so you can see it then still. Then we go to the next question of Johansson.
Yeah, Gudmundur Johansson, adult endocrinologist from Gothenburg. You asked us, could you elaborate on how to manage the increased cancer risk?
That's quite a difficult question. So the increased cancer risk, we know that the cancer risk of all ages is about increased from 5 to 8 times as frequent as in other persons. And that doesn't need a surveillance program. So you can be open for issues. But in patients starting with growth hormone treatment, I'm still careful when the genotypes are from PTPN11 with specific leukemia-prone genes. I always discuss this very well. Thankfully, the problems mostly develop in the first 4 or 5 years, so rather early. So then you can, when there hasn't been a problem up until then, you can be I think, pretty confident you can start with growth hormone. But of course, you should counsel the parents in doing this. So that's how I do it. And I always discuss with the geneticist on those cases. What do you do, Giovanna?
Yes, we do the same, but then moreover, I was thinking about the CNS tumors that have been reported in the literature, and then I would go for if they complain on headache or if double, how do you say, dizziness or vomiting or whatever. So you should go really for symptoms and be very open-minded there. I think the problem of leukemia is difficult. I mean, they have this increase of bleeding. So even if, I mean, we yearly we take we look at leukocytes and so on, the blood status, but you can't do it too often. So it has also to be symptoms that can guide you. Yeah.
And then to the next question, are there any particular genotypes in which you will not prescribe growth hormone? It's something about the last question, the former question, I would say, to cancer risk, and the same with regard to hypertrophic cardiomyopathy, like in RIT1 or REF1 mutations. But also these develop in the first years of life, so you can be there also reassured when this is not the case. Although Giovanna also saw patients developing at a later age, and also Jacqueline Noonan always said to me, please look at the persons with Noonan syndrome also when they're older, because they can develop cardiomyopathy. But I didn't see that myself. And then do you agree with that, or would you exclude patients from growth hormone treatment?
Now, times ago, I would say yes, I would exclude, but now I think that having the dialogue with the genetic unit, I feel more safe in that way. So I would not say just exclude.
And you say, do you think that combining Noonan patients' data at the level of Endo-ERN would increase insights into the condition? Yeah, definitely. And it should be done. And that's also a case to do genotyping these patients to be able to sort out genotype phenotype correlations also for adverse events and for response to treatment. Have you ever come across a Noonan patient with anorgasm? I didn't. Did you?
No, that's the cryptorchis that we see.
So that would perhaps be a coincidence with the vanishing testis syndrome or somewhat. Yeah, it's difficult to elucidate on a specific case when you won't have the details. Perhaps you can write an email, so that's also a possibility.
And we have one question more from Agnieszka. Do you have treatment recommendations for patients with the NF1 syndrome? I would say that I'm the responsible for the National Growth Hormone Registry in Sweden for children, and we have treated neurofibromatosis children with growth hormone, so it's not prohibited, but we are aware of the increased risk of malignancy, especially in CNS.
I agree. It's not a contraindication, and a lot of data on NF1 from the former KICS registration also. Those are.
In the new guideline, would we find a new scoring system?
That part hasn't been finished yet. I really don't know. I think it would be no, because it's more going into genotyping, of course, and the older, I guess the older system can't be changed at this moment, and we don't have enough data to provide a new scoring system, I would say. But you have to have a lot of experience and see a lot of patients, I would say, and to be open-minded.
But I think that it is really important to use the Endo-ERN to have combining the Noonan patients. I think this is really important for the future.
And I guess then there's the last question from Nicolinda. Do you have experience with the LZTR1 mutation? Do you treat with growth hormone? I don't have experience.
Either me. No, we don't.
Okay. I think that we have covered all questions. Actually, you have covered all questions. Thank you for that. Is there anything else you would like to cover before we wrap up? Giovanna and Kees?
No, I would say thank you for listening, and I hope that the guidelines will be available in the course of this year, but it depends upon the different chapters being worked out still, so and being discussed.
Yes. Yes, and please don't forget to inform Endo-ERN so we can use our dissemination channels for spreading the guideline amongst all colleagues in Europe.
That's
okay.
a good tip. Yeah.
Yes. Well, thank you very much for your valuable and excellent talks, and thank you all participants for attending today's webinar. And that's well, we welcome you to any other future Endo-ERN webinar. And yeah, so like we said before, the recording of the webinar will be available in a couple of days, and will always be possible for reviewing at our website. And I wish you a very nice rest of the